Kind of excited to give this talk. As you know, I talk a lot about physiology. Today, I may surprise you. It's going to be more cardiovascular than respiratory physiology. For those of you who don't know, POTS is an acronym for postural orthostatic tachycardia syndrome. Some people say we should drop the O because it's postural, it's by definition orthostatic. But I want you to become acquainted, at least familiar with this, because they may show up in your office. We'll talk a little bit about the regulation of breathing and interactions with the cardiovascular system, and I may even surprise you with some of the data and suggest possible explanations for what ails these patients. And what ails these patients is pretty much depicted in this slide. Common scenario, adolescent girl comes to the primary care complaining of dizziness, and in fact, surveys show that 25% of adolescents experience postural dizziness at some time or another. The incidence of syncope is much less, and in fact, in POTS per se, syncope is the exception rather than the rule. They may faint once, maybe twice, but not recurrently. That's usually something else. So the diagnosis of POTS is based on the presence of symptoms of chronic orthostatic intolerance plus demonstration of postural tachycardia. Now, the poor man's way to demonstrate a postural tachycardia is to simply have them lay down on the bed for several minutes, listen to nice music, measure their heart rate then, and then have them stand up, and they have to stay as still as possible, kind of like the guards at the palace, for at least 3 minutes, and you measure the change in heart rate. The trouble is that's not very well standardized, and you'd be surprised at how much just sort of wiggling your toes and flexing your calf muscles will increase venous return to the heart. So the better way to do it is with a tilt table test, and the patients are rapidly turned from the horizontal position to 70 to 80 degrees upright, and we have all the monitors on while that goes on. A significant postural tachycardia is defined in adults as a change in heart rate of more than 30 beats per minute, and in adolescents more than 40 beats per minute. And it is not, by definition, accompanied by postural hypotension, because if you do develop hypotension, then the tachycardia is an appropriate response. This is inappropriate tachycardia. So step back and think about it for a minute. The baroreceptors, and I'll talk about them a little bit later, they basically maintain blood pressure in a variety of circumstances. So if you've been laying down for any length of time, your heart is at the same level as the rest of your body, then you suddenly stand up. Well, you have to maintain that cardiac output to the head, which is now going against gravity, otherwise you will become dizzy and may even pass out. But in the immediate change to the upright posture, there's a drop in venous return to the heart, and that reduces preload, therefore reduces cardiac output. There's a slight dip in arterial pressure that's sensed by the baroreceptors, and then they send afferent traffic up to the vasomotor center located in the medulla. That center responds by increasing sympathetic nervous system output, which does many things, causes some peripheral vasoconstriction in selected beds, raises heart rate to maintain cardiac output, and the net effect is you'll have an initial slight dip in arterial pressure, but you won't feel it, and within several seconds your hemodynamics will stabilize. So that's what should happen normally. But what happens in POTS? Well, I mean, if you want to explain it in simplistic terms to the patient, you have to start with understanding that the autonomic nervous system regulates more than just heart rate and blood pressure. It actually regulates digestion through motility and through blood flow to the gut, regulates skin temperature and color, again by vasoconstricting as needed, and it has a great many functions, as you know, and that autonomic nervous system is out of balance in these patients. Now, the common symptoms that the patients will tell you about, we'll all recognize dizziness, visual changes such as blurred vision, stands to reason. They'll feel palpitations as their heart races. A lot of them also complain of abdominal complaints, bellyache, nausea, chronic headache. At least a third of them seem to get that. Unfortunately, it's often commingled with fatigue, which makes it difficult to parse out all these symptoms. But about 25% will actually report dyspnea. And if you're a respiratory physician, these patients may show up in your office with that as their chief complaint. And as I said, syncope is not all that common in this population. So this is my little slide to just take a breather and change your track. So what happens in the normal individual when you go from the supine to the upright posture? This has been documented in several studies. You can see that minute volume, how's the pointer working? And yeah, Claire said it's not working all that well. Well, in the top left, for me, minute volume goes up, and tidal volume predominantly is the main response in the lower left panel. Respiratory rate doesn't change all that much. And same thing, in end-tidal PCO2 in the bottom right-hand panel will obviously fall. Only a few millimeters of mercury, but this occurs normally, okay? In you and I, don't have to have POTS.
You can use the cursor.
I can use the, oh, that's true. Thanks, Gary. Now, a friend of mine, Julian Stewart, has been studying this disorder for decades, and he's recently enlisted me to help with interpreting some of his respiratory data. So this is one of his early papers that showed in POTS in particular, so you have, here is end-tidal PCO2 and here is minute volume, and it's relative minute volume because he didn't actually have them on the mouthpiece. That would alter breathing in itself. So he would use respiratory inductance plethysmography to get a handle on minute volume. So minute volume goes, and he studied healthy controls, the black line, POTS who did not complain of dyspnea and who did not hyperventilate and develop hypocapnia. So the HC are the hypocapnic hyperventilators, and the NC are the normal capnic POTS patients. So the normal capnic POTS patients, like the healthy controls, experience a slight rise in ventilation on assuming the upright posture and a slight reduction in end-tidal PCO2. But this group of POTS patients, the changes were much more dramatic. So why is that? Well, let's talk a little bit about the control of breathing. You have your respiratory center located in the medulla, and very near to it is the central chemoreceptive area, which responds primarily to carbon dioxide and acid. You have your peripheral chemoreceptors located primarily in the carotid bodies, which respond to decreases in arterial O2. And this is subtle, and we'll talk about this later. Is it PO2? Is it content? Is it saturation? Just what is it? The aortic bodies will respond to some extent as well. And it just so happens that the aortic bodies and the carotid bodies are also the main baroreceptors. And of course, you have higher centers in the brain that can exert influences on this respiratory center, which gets feedback from the intercostal muscles and sends signals down to the diaphragm, and that's how and why we breathe. So, dyspnea. What is dyspnea for these patients? Well, for those of you who've heard me talk before, the common theme is dyspnea essentially represents a mismatch between the neural signal that descends from the respiratory center to the respiratory muscles and the feedback that is received in response to that neural signal. Now, we're wired somehow early in life to expect a certain change in blood gas or maintenance of normoxia and eucapnia, and to expect a certain volume displacement for that neural signal. And that registers up in the supratentorial lesions in parts of the frontal and temporal lobe called the premotor cortex and the cingulate gyrus. So these areas are should expect a certain amount of afferent feedback from this active breathing. And when that doesn't match the neural signal that went down, that's how we perceive dyspnea. That's the usual mechanism. It has been shown experimentally that merely being aware of breathing more can also create a sense of dyspnea. So those two factors are predominantly what causes a person to feel dyspnea. And again, let's get a little more specific. The carotid bodies, baroreceptors, and chemoreceptors located right here. The aortic bodies also respond to hypoxia, though not as strongly as the carotid body. And these are the two main baroreceptors. And collectively, they're called the peripheral chemoreceptors. And then you have your central chemoreception in the medulla, right in this area here. And this area is this will be the most detailed slide I have. So here are a group of nuclei in the medulla, and this one here, the nucleus tractus solitarius, this is where a lot of the cardiac, cardiovascular afferent signals are received, processed, and then sent forward to the appropriate places to respond. And it's very close proximity to the respiratory rhythm generator and to other cardiovascular centers. So this proximity is of functional significance as well. To reiterate, the baroreceptors are the primary sensors for blood pressure control. Peripheral receptor in the carotid body also plays a role. And inputs from both baroreceptors and peripheral chemoreceptors can affect the cardioinhibitory center and the cardioaccelerator center that are located adjacent to them in the medulla. And I'm going to show you experimental evidence that supports that. So, my colleague, my friend Julian, demonstrated that there is actually a ventilatory baroreflex. So that's right. It's you change your ventilation not in response to a change in PO2 or PCO2 or acidosis, but in response to a change in your hemodynamics. And he did this using something called the Oxford maneuver, and that's what this little inset here is. What they do is they'll alternately administer sodium nitroprusside to cause vasodilation, and therefore your heart rate's going to jump because now you're all peripherally vasodilated and cardiac output will have to increase to maintain pressure. And then they'll give phenylephrine to cause vasoconstriction. And what happens now? Cardiac heart rate is going to fall because now your blood pressure is just fine and you don't want to be pumping excess blood into that circulation. So that's the Oxford maneuver. So what he did was he took patients with POTS and he had them do this, he subjected it to this Oxford maneuver, breathing 3 different gas mixtures. Room air, 10% oxygen, which is obviously hypoxia, stimulating the carotid body, the main peripheral chemoreceptor. 30% oxygen and a little bit of inhaled CO2. The 30% oxygen will effectively shut any afferent information coming from the carotid bodies because they're bathed in oxygen now, just with that 30% O2. But by giving the extra CO2, that's reacted to predominantly by the central chemoreceptors in the brainstem. So he did the Oxford maneuver under 3 different gas conditions, and he measured changes in ventilation, changes in respiratory rate, and changes in tidal volume. And you can see that just altering blood pressure caused quite clinically and significant changes in minute volume, in respiratory rate, and in tidal volume. And the changes were similar in the 2 gas conditions. So he got the same change when the peripheral chemoreceptor was shut down, and he got the same change when it was activated by the hypoxic mixture. So therefore, he was able to show that ventilation changed not because of gas mixture, but because of changes in blood pressure. And he showed about a 100% rise in ventilation during sodium nitroprusside infusion that will cause a drop in blood pressure across all the gas conditions. And this, it's called baroreflex unloading, is relatively large and independent of chemoreflex activation because it was the same across all gas mixtures. And this is physiologically important because he didn't cause much of a change in arterial pressure, 10 to 20%. And anyone could easily experience that, at least transiently, assuming the upright posture. So now is my shameless plug for exercise, because you know I'm an exercise guy. Most of us do exercise in the upright posture, as is shown here. And I've tested hundreds of kids with POTS during exercise, and I always ask them at the end, all right, why couldn't you go on anymore? What made you stop? And they usually say, I was just too tired, my legs were sore, I was out of breath, or I was dizzy. So what we found is that the patients who stopped because of dizziness tended to have lower end-tidal CO2, not at peak exercise, but at the ventilatory or the gas exchange threshold, which is a pretty standard point during an incremental exercise test. And end-tidal CO2 in the other POTS patients were pretty similar, who ceased exercise complaining for different reasons. So I thought, okay, they get dizzy, they hyperventilate, they get dizzy, it drops their PCO2, it probably affects cerebral blood flow, and that's why they're dizzy. But then Julian, around the same time that I was publishing that, he published this study here that again, he showed in patients with POTS and controls, so the controls are the dark lines, patients with POTS are the gray lines. He tilted them and measured it with fine detail the changes in respiratory rate, minute volume, end tidal CO2, and tidal volume. And as expected, the controls ventilation goes up slightly, end tidal CO2 goes down slightly, and in the controls respiratory rate doesn't change much, tidal volume rises a little bit, and that's how their minute volume increased. The POTS, it's an exaggerated response, and again, he selected POTS who reported dyspnea. End tidal CO2 fell, and it was due predominantly to a rise in tidal volume. Okay, what's the big deal? We kind of know that. Didn't he show that already? In case you're wondering if the patients panic, because this is often, because these patients tend to be sort of high achievers, type A, if you believe in that personality, are they just panicking or something when you tilt them up? So what he did was he studied controls, patients with a panic disorder diagnosed by the DSM-5, which is how the psychiatrists diagnose mental disorders in North America, and in control, so healthy controls, and he also made another group of controls hyperventilate during the tilt. And basically what I want to show you in this complicated slide is that controls, again, subtle changes in tidal volume, in respiratory rate, the dark line, in minute volume, going from 9 to 10.5 or something, subtle change in end tidal CO2. Cerebral blood flow, that's what he measured this time, dropped a little bit in the healthy controls. It dropped a little more in the POTS, in the panic patients, and in the controls who hyperventilated, but it seemed to drop the most in the POTS patients. Okay, they stand up, cerebral blood flow falls, they hyperventilate. Does that sort of worsen their cerebral blood flow? Because we know that hypocapnia causes cerebral vasoconstriction for the intensivists in the audience. But the changes in panic, though, are different from POTS, and that's what I'm showing you here. Healthy volunteers, when they assume the upright posture, mean arterial pressure falls slightly. In POTS, the hyperventilation groups, the hypocapnic ones, it rises, and it rises in panic disorder. This is probably a little sympathetic discharge. However, cardiac output eventually rises in the POTS, rises in the panic disorder, rises in the healthy controls, rises in the panic disorder, but POTS, cardiac output actually falls, assuming the upright posture, because they have no preload. And how do they compensate? They compensate by increasing systemic vascular resistance and maintain blood pressure, because normal healthy volunteers, their blood pressure will dip slightly. And panic disorder, this is probably all a reflection of sympathetic discharge. So the point of this slide is they're not just panicking. Patients with POTS who complain of dyspnea, who develop hypocapnia, something changes in their circulation that affects their breathing when they assume the upright posture. And so here's another slide from that same study. He did even more detailed studies. What he did was look at where is all the blood going. Remember I said when people assume the upright posture, the blood will pool below the diaphragm. So where is it pooling? And he looked with something called the electrical bioimpedance in the thorax and in the gut. So thoracic volume fell in the POTS patients tremendously, low preload, that's why their cardiac output drops. And seemed to get sequestered somewhere between the diaphragm and the pelvis. Cerebral blood flow dips slightly, but not significantly in the controls, dips big time in the POTS patients. You've seen this, it's got to be the third slide I'm showing you. End tidal CO2 drops. And at the same time, they activate their sympathetic nervous system. This is a measure of muscle sympathetic nervous system activity. So that's how they're trying to compensate for all these changes on assuming the upright posture just after a few minutes. But when you look carefully at this, here's a representative tracing from a given patient with the POTS hypocapnia, hyperventilator. They're laying flat, they get tilted. This is actually ventilation. I pointed this out to Julian. That's not heart rate. Their ventilation goes up, end tidal CO2 goes down, cerebral blood flow goes down, and here's the heart rate. This is the real heart rate right here. And if you look carefully, this vertical line is the same time. So ventilation jumps almost immediately, but cerebral blood flow seems to be a little bit of a delay there. And in fact, when you magnify the time window, this is what actually happened, is cerebral blood flow started to fall even before the onset of hyperventilation. So I show you that to tell you this, that this reduction in cerebral blood flow may not be the consequence of hyperventilation and hypocapnia. At the end of this, I'm not going to have a final answer for you. I want to get you to think about this when you see these patients, because this is what I like about the job I do. And the average time delay between the fall in cerebral blood flow and the onset of hyperventilation averaged about 17 seconds. So something is going on in these patients, and the question is, all right, what's chicken and what's egg? Does cerebral blood flow fall first and then they hyperventilate, or do they hyperventilate and that causes cerebral blood flow to fall? Well, it's even more complicated. And here, I'm coming to the close, here we have to sort of think about what's going on in other disorders. And there's a growing literature on the effects of intermittent hypoxia that is seen in obstructive sleep apnea syndrome. The sleep guys will know this. And also in congestive heart failure, how it affects breathing. And if you have intermittent hypoxia, you will, over time, change how the carotid body responds. And this response will persist even after you correct the intermittent hypoxia. And that's called long-term facilitation. And it's been shown that the gain of the carotid body, meaning how much will it stimulate your breathing in response to a fall in oxygen, the gain increases in patients with obstructive sleep apnea, presumably because of this intermittent hypoxia that they're experiencing during the night. And even in heart failure, carotid chemoreceptor activity is tonically elevated in these patients, and it probably contributes to their morbidity due to increased reflex activation of the sympathetic nerve activity. And in fact, this increased gain of the carotid chemoreceptor destabilizes their breathing, and that's why these patients, the combination of heart failure and sleep apnea, their breathing really gets messed up. And that's when you see the Shane Stokes and that, or Cheney Stokes. So it was initially old school, and I had trouble buying this argument because I was always taught carotid chemoreceptor responds to PO2, partial pressure of oxygen in the blood. But you know, what if the cause of the low oxygen in the chemoreceptor is a drop in the blood flow? Don't forget where it's located. It's above the heart, it's in the neck. If I spent the first 15 minutes telling you how blood flow going up that way falls when we assume the upright posture, maybe it's a problem with reduced oxygen delivery repeatedly in these patients with POTS that resets or has reset their carotid chemoreceptor. This is just our hypothesis. So I don't have any proof for this, but this is where we're headed. So all is not lost. Getting back to the patient, you can explain to them that because of this autonomic nervous system imbalance, the blood vessels relax and become wide. So instead of the tube, the person going down the river in their tube nice and fast, here they're just sort of meandering along. And these relaxed blood vessels are less efficient returning blood to the heart when you stand up because it all pools down in the legs. Results in poor circulation. They can get changes in the color of their extremities. But treatment, there is a treatment plan. It's called the STEPS approach. For those of you pediatricians who may see them, you increase your salt intake, drink plenty of fluids, 2.5 liters a day in females, 3 liters a day in males. They have to start exercising. Prescription drug may or may not help, and they have to get adequate sleep as well because that's disturbed. Our treatment approach when I was at Mayo Clinic is summarized in this paper, and the bottom line is these patients will get better with appropriate management. This was a follow-up study from Mayo Clinic. So I wanted to talk about this, A, because I'm interested in control of breathing, and B, because when I first saw these patients, I really thought they're just nervous, panicky, you know, that's why they're hyperventilating. They don't have any disease. Well, they don't have any lung disease, but they really do have something wrong with their circulation that affects their breathing. And if you see them in the clinic, recognize what's going on, and at least you can make an appropriate referral rather than just dismissing them and sending them on their way, because it's not all in their heads other than the blood flow. Thanks very much.